On behalf of my colleagues and Executive Committee of Dubai Pediatric Club, I would like to welcome all viewers from Dubai, UAE, GCC countries, and all countries across the globe, especially from India and Chandigarh. We have eminent speaker and panelists tonight. The topic is an update on pediatric intensive care, fluid and electrolytes therapy in neonate, infant, children, and adolescents. This webinar is CMA accredited and is conducted in collaboration with NMC Specialty Hospital and is sponsored by Vitabiotics UAE. I would like to thank the country business manager of this company, Mr. Tawfiq Ali. Well, we have eminent speaker and panelists. In a short while, I'll be introducing them. Well, Friday, 13th May was a sad day for the people of UAE. His Highness Sheikh Khalifa bin Zayed Al Nahyan, UAE President and ruler of Abu Dhabi, passed away on Friday, 13 May 2022. May God rest his soul in peace. On behalf of all members of the Dubai Pediatric Club, we extend heartfelt condolences to the respected people of the UAE and mourn with them. Also, on behalf of all members of the Dubai Pediatric Club, we would like to congratulate His Highness Sheikh Mohammed bin Zayed Al Nahyan on being elected as President of the United Arab Emirates. Well, there is a question always. They are the three pioneers in the field of pediatric intensive care. I would like to request the viewer just name and tell us why they are famous. You have about 3 to 5 minutes time. Mr. Tawfiq, you can write their names. Welcome to Dubai, one of the most beautiful cities in the world. Those who have not seen, I would like to request them to come and see. Members of Dubai Pediatric Club, you see here Dr. Parveen Khillani. Today I will talk about him. He is one of the pioneers in the field of pediatric intensive care in India and UAE. Well, the members of organizing committee of Dubai Pediatric Club, myself, Dr. Rajendra Joshi, the past president, Dr. Kalpana Sen Gupta, secretary of the club, Dr. Diari, chairman of the academic affairs, Dr. Amir Muhammad Tolemat, Dr. Ayman Jundi, Dr. Rafia Ovara, Dr. Srinivas Pandari, Dr. Leila Bahi, and Dr. Khalid Rashid. Well, as I said, today we have eminent speaker and panelists. I have circulated and sent to all groups the profile of the speaker and panelists. Our speaker is Professor Jayashari Muralidharan, consultant pediatric intensivist at Advanced Pediatric Center, Postgraduate Institute of Medical Education and Research, Chandigarh, India. We have also eminent panelists, Dr. Intisar Al-Hamadi, consultant pediatric nephrologist at Al Jalila Children's Hospital and many other private hospitals, including Zuleika Hospital. Dr. Monica Rochelle, consultant pediatric, consultant neonatologist and director of the Emirates Specialty Hospital, well known to everybody. Dr. Deepika Gandhi, consultant intensivist at NMC Royal Hospital, Sharjah. We have also moderators, Dr. Sunil Pubani, senior consultant pediatric intensivist at Mediclinic City Hospital, and Dr. Kalpana Sen Gupta, head of Department of Pediatrics at NMC Specialty Hospital and secretary of the club. In a short while, I'll be introducing them. Well, our sponsor, Mr. Tawfiq Ali, I would like to inform the viewers that early this month, Mr. Tawfiq lost his mother. On behalf of all members of Dubai Pediatric Club and Executive Committee, I would like to sympathize with this sorrow. May God rest her soul in peace. Well, few days back, it was World PICO Awareness Day. So this webinar is to increase awareness of the people regarding PICO and the fluid therapies. Well, very briefly, I would like to tell you about the history of pediatric intensive care. Well, always I start my talk in the memory of Hippocrates. One of the quotations of Hippocrates, it is written on the wall of one of the emergency department of one of the medical schools in the United States. And this by itself defines PICU. Life is short and the arts long. The occasion instant, experiment perilous, decision difficult, moments matter. This is the definition of PQ. Well, I love this quotation by Isaac Newton. If I have seen farther, it is by standing on the shoulder of the giants. Who are the giants? They are the giants who showed us the way, and today we are treating our patient with fluid therapy. Sir William O'Shaughnessy, his medical research led to the development of intravenous therapy. Thomas Latta invented the intravenous saline infusion in 1832. James Campbell, remember his name, very famous professor of pediatrics, Harvard Medical Institute, Boston, a pioneer in salt and water disorder. Daniel Darrow, everybody knows about the Darrow solution, invented Darrow solution, and Ben Fries Hansen, a Danish pioneer of neonatology and pioneer research in body composition. Those who have worked in body composition, they know him. I would like to tell you something about this Boston. All this research started on cholera. In Boston, there were floating hospital. It was called Boston Floating Hospital. Why? They used to keep the children with cholera, take them to the sea. Out of 10, only one could survive and come back. The rest 9 were buried in the sea. This was the situation. And on the research of these scientists, we are having fluid therapy today. Now, the first pediatric ICU was established in Europe by Goran Hogland in 1954 at Children's Hospital of Göteborg in Sweden. Now, the first, Mr. Tawfiq, we are not receiving any answer. This gentleman, John Donis, opened the first pediatric ICU in the United States at Children's Hospital of Philadelphia in 1967. Here you are seeing with his boss, Dr. Bachman, and he is describing a patient in the intensive care unit. This gentleman, the pioneer, Dr. Donis, was the anesthetist in chief at the Children's Hospital of Philadelphia for almost 25 years. And he was the one to establish in 1967 the PICU, when the CHOP inaugurated pediatric intensive unit, the first of its kind in the United States. Well, here you are seeing here with his boss, Mr. Bachman, and this is Dr. Donis. Well, now, with the growth of hospitals with PICU in the early 80s, the American Academy of Pediatrics and the pediatric section of the Society of Critical Care Medicine set forth guidelines in 1993 for PICUs. And now I would like just to mention why American logo is this. American logo in 16th century, children they were suffering from rickets. In those days, they thought if they wrap the legs with the rope and keep the child in sun, it will be cured. So rickets and vitamin D deficiency, this is the logo of American Academy of Pediatrics. Well, Dr. Donis identified 5 crucial fields of medicine in 50s that led to the emergence of pediatric critical care. What were those? Adult respiratory intensive care, neonatology and neonatal intensive care, pediatric general surgery, pediatric cardiac surgery, and pediatric anesthesiology. Well, this is the thing in the 30s to 50s. Adult respiratory intensive care units were created to battle the scourge of the polio epidemic with iron lung ventilators. Well, you remember I talked about this gentleman, Dr. Everett Koop. Later on, who became general surgeon in the United States, developed the first discrete post-surgical care area for infants in 1956 with a dedicated nursing team. His capacity and staffing increased in 62 to become the first modern infant ICU in North America to primarily care for post-surgical neonates. Now the second gentleman, Mark Rogers, everybody knows about him. I understand. Professor of Anesthesiology, Critical Care Medicine, and Pediatric at Johns Hopkins. Was recruited in 1977 to become the first director of the Pediatric Intensive Care Unit. Now, here you see he's the head of the anesthesiology. Here, he has been introduced to the governor of Maryland. By whom? Can you guess who is this? Oski, Frank Oski, the head of the Department of Pediatrics then, who has written Oski and Nathan and Oski, Hematology, those who have read. And this is Dr. Mark, and this is his book, the first textbook of PICU. I'll talk about this. And about the books and journal, Mark Rogers is credited with introducing the first comprehensive pediatric critical text book in 1987. Textbook of Pediatric Intensive Care. Our panelist today, Dr. Deepika Gandhi, is the Asian editor of this book. In 1995, David Nichols published the first pediatric cardiac critical textbook, Critical Heart Disease in Infancy. And in July 2000, the specialty's first and only journal, Pediatric Critical Care Medicine, was established, just to remember them. And this is Dr. Randolph Wetzel. In 2000, the first internet database, the virtual PICO, was founded by Dr. Watson in Children's Hospital of Los Angeles. Just remember his name. Now, they are the pioneers in the world, in India and in the UAE. Just remember them. In India, well, pediatric intensive care in India started in the early 90s, almost simultaneously at 4 centers in North, South, and West by individual efforts. The pioneering institution were PGI Chandigarh under leadership of Dr. Sunit Singhi. At Sir Gangaram Hospital, Delhi, Dr. Krishan Chuk. At Hinduja Hospital, Mumbai, Dr. Sonu Udani. And at Child Trust Hospital, Chennai, Dr. Suchitra Ranjit. Remember them, they are the pioneers. Now, IAP introduced pediatric advanced life support courses in early 90s with the help of a specialist from the United States, especially Dr. Janaki Raman. Here you see him here. Dr. Singhi, here is our speaker, Dr. Jayashri, with others. In 1995, formal IAP PALS courses were launched with Dr. Sunit Singhi as the first national convener. Please remember them. Well, a formal pediatric intensive care unit was formed within Indian Academy of Pediatrics in 1994 under governorship of Dr. Chuk. Subsequently, it became IAP Intensive Care Chapter under chairmanship of Dr. Singhi in 1998. A pediatric section also started within Indian Society of Critical Care Medicine with Dr. Parveen Khildani as the first chair. Dr. Parveen Khildani is known to everybody. He was in Dubai. He's a member of Dubai Pediatric Club. He is multi-talented. Well, the teaching tools, short courses, but various institutions created a demand for more organized formal training. In the year 2005, pioneers, Dr. Singhi, Dr. Chok, Dr. Udani, Dr. Ranjit, and Dr. Khilnani decided to form a Pediatric Critical Care Council with the aim to develop a one-year course under the aegis of the Indian Academy of Pediatrics and Indian Society of Critical Care Medicine, just to remember them. Well, a full-fledged 3-year training course, DM Pediatric Critical Care, was started for the first time in India in 2009 at PGI Chandigarh under the leadership of Dr. Sunit Singhi. Dr. Sunit Singhi, this is a 2014 at Istanbul, Asian PICU group at the World Federation of the Pediatric Intensive Critical Care Society. This is our speakers. Very humble standing here, Dr. Jayashri, and Dr. Singhi was president. Well, I take this opportunity to remember my teacher in late 80s. I was lucky enough to get these giants as my guides and mentors. Dr. Sunit Singhi, pioneer in PICU, Dr. Narang, pioneer in NNF in India, and Professor Baku, the father of pediatric neonatology in India, just to remember them. And this is just in brief how evolution of neonatal and pediatric care developed in India. I'm not going through that. Well, this you see here, our speaker, Dr. Jayashri, they develop a system in the emergency department, how to categorize the patient according to their need and severity. Well, during COVID also, our speaker, Dr. Jayashri, was very active. Here you see Dr. Ashok Diorari, there was a COVID webinar. You see here Dr. Kapra, Dr. Lodha from All India, and Dr. Singhal from Bombay. Well, these are the book. This is a book written by Dr. Sunil Singhi, the fourth edition, Basic Pediatric Intensive Care. Dr. Parveen Khilnani's book now, fourth edition, is out. Pediatric Intensive Care, a Practical Approach. And Dr. Jayashri and Dr. Sonu Udani, they have written this Pediatric Intensive Care IFP Specialty Series, just to know. Well, beautiful city of Abu Dhabi. In UAE, the PICU was originally set up by Dr. Howard Home, consultant pediatric intensivist at Sheikh Khalifa Medical City, as a 6-bed unit in early 2000, within the adult ICU, and was the first PICU in Abu Dhabi. I would like to bring to your attention that Dr. Hone still is there. He is the chair of the intensive care unit, and for 22 years he is there. Well, our speaker, Dr. Jayashri, or better Professor Jayashri Murali Taran. Well, I've sent the profiles to all the groups. For the sake of time, I'm not going through it. Professor Jayashri is a consultant pediatric intensivist at Advanced Pediatric Center, Postgraduate Institute of Medical Education, Chandigarh, India. She is the author of the book, as I mentioned, and she is the editor of this journal, The Intensivist, and many other publications. Well, our panelists, Dr. Intisar Al-Hamadi, consultant pediatric nephrologist at Al Jalila Children's Hospital and Zuleika Hospital, and attached to many other private hospitals. She is one of the pediatric nephrology speaker invited to almost all conferences in the UAE and in the region. Very famous. Well, Dr. Monica Rochelle, well known to everybody, consultant neonatologist at Emirates Specialty Hospital, Dubai. She is the medical director of this hospital. Please join me in congratulating her. She has authored the Asian edition of Cloarty. All of you know Cloarty and Stark Neonatology, and textbook of clinical neonatology. Nowadays, if you open any book, especially in India on neonatology, you will find somewhere the name Monica Ghoshal, Dr. Monica Ghoshal. And our next panel is Dr. Deepika Gandhi. As I mentioned about Dr. Raja's textbook, Dr. Dr. Deepika is the Asian editor of this book, along with Dr. Kamat. They have also written another book, Pediatric Critical Care Manual. So those who are interested, they can go through. Well, our moderator, Senior Dr. Sunil Buboni, Senior Consultant and Chief of the Pediatric Critical Care Unit at Mediclinic City Hospital and Associate Professor Clinical Adjunct at Mohammed bin Rashid University, Dubai. He is also contributed in this book, Extracorporeal Life Support. You see here his name, Dr. Sunil Buboni. Well, my references, beautiful Dubai, one of the most beautiful cities in the world. Now I would like to request Professor Jayashri to please start her talk. I would like to request all the viewers to write their question in the question and answer book. Thank you very much. Over to Dr. Jayashri. Thank you very much.
Very good evening to all of you. I'm very thankful to Dr. Saurav for having given this, for having taken me through this nostalgic trip of pediatric intensive care, especially in India. I thank the Dubai Pediatric Club for having given me this opportunity to share my views on fluids and electrolytes in critically ill children. And I would begin by thanking my mentor, other stalwarts, teachers, and so many of my students, my colleagues, my friends from the Pediatric Intensive Care Group, from all over the world who have joined for this particular webinar, and for all the participants. Thank you very much. So I'll just confirm once whether the screen is visible and the audio is fine, and then I would proceed. Is this okay? Is the screen visible?
Yes.
Yeah. Okay.
Yes.
So this topic, fluids and electrolytes in children, that too critically ill children, is a very vast topic. And I'm not sure if I would be able to touch upon every query that the participant would have who have logged in for this particular webinar, but I have tried to conceptually place the facts as well as the evidence so that it covers most of the areas where we always kind of find difficulties in understanding fluid and electrolyte therapy in critically ill. So the landscape of my talk, basically to put it in a nutshell, would be the why, how, when, and what of fluid therapy with specific reference to critically ill children. So I would talk about the phases of fluid therapy, the constant debate that one always has when we talk of fluids, whether it's isotonic versus hypotonic, whether you need to give restricted versus normal infusion rates. How do we remove the extra fluids once you have finished resuscitation in a child, what is called as a targeted de-resuscitation? And there are several disease states. We all know that fluid therapy is never a one size that fits all. So there would be a fluid prescription which would differ according to the disease states. And of course, the last would be the summary of what this particular talk and what the take-home messages would be. So in one of the review articles, very nicely, it has been described that fluid therapy is basically a reverse nephrology. So I know that we have a very esteemed nephrologist in this panel, and she would be contributing more to the discussion at a later point in time. So normally for a pediatrician, the indications of fluid therapy are to normalize hemodynamics, to return the intracellular fluid volume to normal, replace the ongoing gut or renal losses, provide glucose to the brain, and give maintenance fluid to match the insensible losses. So usually the fluid indications are either resuscitative, either you replace, or either you maintain. So IV fluid, like when I remember during my residency days, starting fluids for a child would be like mostly done at a spinal level. It would just come naturally. You just keep charting on the prescription charts. But over the years, IV fluid has become very complex with increasing advances and different kinds of disease states. And so it's no longer as innocuous as once it was thought to be. So there are several facets in IV fluid therapy which have been really researched to great details. And as pediatricians, we need to be aware of what is happening in this particular field of critical care. This is a very beautiful concept when we talk of fluid therapy in critically ill child, what is called as the ROSE concept. It's an acronym where R stands for rescue or resuscitation, O stands for optimization, S for stabilization, and E finally is for evacuation. So basically the fluid needs in any critically ill child goes through certain phases which start from minutes, hours, days to weeks. And therefore it is important for us to understand that fluid needs are very dynamic. They will keep changing according to the disease state and the history of the natural disease in a given child. So therefore what we calculate and what we give at one point in time may be very different if we see it 2 days later or maybe a week later. The fluid needs will be completely different. So when we chart fluids, we need to keep this particular concept in mind. So the next 20 to 30 minutes, I would be taking you through a case and explaining this ROSE concept and how we need to chart fluids when we are at bedside along with a sick child. So let us look at the story of Master M, who was a 9-year-old child who presented to the pediatric emergency at PGI Chandigarh. He presented with fever for 2 days, vomiting for a day, abdominal pain for 1 day, and he had a generalized erythroderma or rash for 1 day. The vital examination showed tachycardia, tachypnea. The central pulses were palpable, but the peripheral pulses were weak and feeble. The child was hypotensive. The fifth centile BP, the systolic BP was 70, qualifying for hypotension at this age of 9 years. The capillary refill time was prolonged at 4 seconds. There was diffuse erythroderma. Other systems, however, were normal. The provisional diagnosis that was kept was child was in hypotensive shock, which was the physiological categorization, and the possible etiology kept was a toxic shock syndrome. So first thing that we need to see now is the R of the ROSE concept, which is the resuscitation phase. So what we need to understand the basics of R are that the hit or the injury is a first hit. And during this phase, the flow, that is the perfusion, is low, what we call as the ebb phase. Therefore, as clinicians, the question that we need to ask is, when do we start fluids and what is the benefit of fluids? What we need to remember is that fluids are mandatory in this phase because we have to resuscitate the intravascular space. The type of fluid that we will use will always be a crystalloid. The rate, obviously, because if a child is hypotensive, the rate has to be faster. So it has to be in the form of a bolus. And our goals would be to correct the intravascular volume and improve the tissue perfusion. And we would target that we optimize both the macro as well as the micro circulation. And the time frame over which we need to do this would be like within minutes to an hour, depending on the kind of hemodynamic status the patient has. So these are the important concepts that we need to remember during the R phase or the rescue or the resuscitation phase. Then there will be certain questions that will come to our mind. So the debate would be volume, whether we would give 20, 10 or 5 ml per kg. How rapidly do we need to push this fluid, whether we can give it over an hour, whether it's 30 minutes or more rapidly 5 to 10 minutes. What is the type of fluid? This is always $1 million question that comes to us, crystalloid versus colloid. And how much would be the total fluid that we would give before we label that a child is fluid refractory, whether it is 60 and less than 60 or whether it is more than 60 ml per kg. So let's see how the concepts have changed over the last few decades. So this is one trial which I think has changed the way we started looking at fluids, especially resuscitative fluids in patients with septic shock, the FEAST trial. I'm sure all of you have heard. So it's very, it's quite easy for us to now kind of divide the understanding of fluid as to something which was pre-FEAST era and something which is now what we are doing is the post-FEAST era. So pre-FEAST, we were more liberal with the fluids that we used during resuscitation, whereas in post-FEAST, we have become quite conservative and we are very particular about what triggers we are going to chase as far as the fluid boluses are concerned. So what is it about this FEAST trial, which was published in New England Journal of Medicine in 2011? So this was basically a paper which talked about mortality after fluid bolus in African children with severe infection. So it was a study which was conducted in a resource limited setting. And this questioned the aggressive fluid therapy that was advocated in septic shock. So what they found, what the investigators found was that bolus fluid, whether it is saline or albumin, significantly increased 48 hours mortality in critically ill children who presented with impaired perfusion. Now, it's important for us to kind of understand the words that impaired perfusion is a very important word here. They challenged the importance of fluid bolus in a resource limited setting for children who are not having hypotension, but they just have impaired perfusion. And those who were on only maintenance fluids, they did better. These children obviously had malnutrition and anemia. Malaria was an important cause for fever in these children. And rapid fluid resuscitation, therefore, the authors felt may not be the best strategy, especially in a resource limited setting. As you can see in this Kaplan-Meier curve, the mortality was higher in those children who received fluid bolus. And subsequently, after the FEAST trial, there have been several more studies who opened this Pandora's box and started questioning the need for excessive fluid and septic shock. And this fluid may be associated with fluid overload and increased mortality. And the children in resource limited and resource rich countries could behave very differently. So the FEAST trial started making us think more about conservative triggers. The earlier septic shock guidelines, we were very liberal with fluid boluses up to 60 or sometimes higher than 60. The ACC-MPALS guideline recommended bolus of 20 ml per kg, sometimes even up to 200 ml per kg, because we thought that septic shock is all about capillary leak and vasodilatation and increased vascular capacitance. So the child requires more boluses to maintain an intravascular volume. And of course, FEAST changed everything and we started thinking about restrictive strategy. And now after FEAST in this last decade or so, clinical practice has moved away from fluid bolus simply to treat abnormal vital parameters without impaired tissue perfusion. So if you don't have an impaired tissue perfusion, but just simply tachycardia, then you're just not going to chase them with fluid bolus. And also at the same time, we need to remember that appropriate triggers are likely to vary between patients and also between the same patient at different points in time. As I said, that fluid needs are very dynamic. Then comes the second question, that is rate of fluid administration. Should we give it fast, 5 minutes, 10 minutes, 15, 20, or should we give it over 1 hour? This study was done in India at AIMS. And here what they found is, the investigators found that children who receive fluid boluses more rapidly, that is over 5 to 10 minutes, had higher risk for intubation than those who are receiving it little slowly over 15 to 20 minutes. However, the investigators did not find any difference in mortality. So basically what this means is that there is a risk of the lung getting clogged when you're giving fluid boluses rapidly. And it's important for us to have adequate provisions for mechanical ventilatory support whenever we are going to give rapid fluid boluses, which many a times may be a difficult proposition especially when we are treating children in resource limited setting. So then the current recommendations. So what happens about resuscitation fluid volume? This is as per the Surviving Sepsis Campaign international guidelines. So they took note of the FEAST trial and subsequent so many trials which talked about rapidity of fluid infusion. And there the guidelines then took into consideration this kind of setting in which one is treating septic shock. So if you have an advanced supportive and intensive care facility and your child presents with hypotensive shock, then you can go up to fluid bolus of 40 to 60 ml per kg in the first hour. That means you know that you have the resources. In case there is a lung problem, you can ventilate the patient quickly. However, in resource poor setting, perfusion abnormality with hypotension, one needs to give a fluid bolus up to 40 ml. So we are conservative here. And the trigger, if you notice, is perfusion abnormality along with hypotension. Then you can use 40 ml per kg in the first hour. But in the same resource poor setting, if you simply have an impaired perfusion, but no hypotension, it is important for you to be very careful with fluid bolus. And maybe these kind of children would do better with just maintenance fluids, as per what was shown in the FEAST trial. So I think the FEAST trial has basically changed the way we look at fluid therapy, especially the resuscitative fluid therapy in children with septic shock. And the bolus volume, rather than being a standard across the board 20 ml per kg, it has been toned down to 10 to 20 ml per kg as per the clinician's decision at the bedside. So this is a major change which has happened as far as resuscitation is concerned. Then the next question during resuscitation would be, as I said, the $1 million question, is it crystalloid versus colloid? And this is a meta-analysis, systematic review and meta-analysis of adult studies where they looked at HES as well as albumin and 5 RCTs in the adults, which they found that resuscitation with crystalloids was associated with a lower central venous pressure. This is an expected kind of a finding, because we all know that crystalloids tend to stay for a very short duration inside the intravascular space. The mean arterial pressure as well as the cardiac index, they were lower in the RCTs where crystalloids were used, but the all-cause mortality and 90-day mortality was much lower with crystalloids. So this is the major problem with colloids. Wherever colloids have been used, one is more concerned about the mortality and the adverse reactions which are associated with colloids. Although they do give rise to better hemodynamic parameters because of their physiological property of staying for a longer time inside the intravascular space. Now, what does the pediatric data say? Because it's not correct for us to extrapolate the adult data to children. So colloids in septic shock, a systematic review in children of 12 studies which evaluated almost close to 4,000 children between 2 months to 15 years. The 5 studies were of malaria, 5 dengue, 1 febrile disease, and 1 septic shock. Now we need to remember that tropical fevers and septic shock are a very different ball game altogether. But here they found that colloids were not superior to crystalloids, and though the fluid volume needed to achieve stabilization was much smaller with colloids as compared to crystalloids. So the final consensus is yet to be arrived, but however, crystalloids still remains the preferred therapeutic options for resuscitation in pediatric septic shock. Then there is a lot of papers and a lot of talk about balanced or buffered crystalloids. These days, many units are using plasmalite. Some units are also using Ringer's lactate. Many prefer not to use normal saline because it's a very chloride rich fluid. So what does the word balanced mean? It basically relates to a lower chloride content and hence a very minimal effect on the acid base disturbance. And there is increasing evidence from observational studies and randomized control trials in adults that resuscitation with chloride-rich fluids is associated with hyperchloremic acidosis because of the high chloride content. There can be a systemic inflammation like picture. Most worrisome complication is the acute kidney injury, which can occur because of an afferent arteriolar constriction, which causes a reduced renal perfusion, coagulopathy, and some observational studies have also shown some association with mortality. So they found these observational studies in some RCT in adult, they found that resuscitation with balanced or buffered crystalloid, the commonest example is a plasmalite or a lactated Ringer's or Ringer lactate, what is called in India, is better as compared to normal saline, which is an unbalanced crystalloid. What does pediatric data say? Which is the crystalloid of choice? So although pediatric RCTs are lacking, large observational studies, especially a matched retrospective study of roughly about 12,000 children less than 18 years in multiple hospitals in US over a longer duration, where they use Ringer lactate versus normal saline. So Ringer lactate is a balanced crystalloid and normal saline is an unbalanced crystalloid. And they looked at outcomes which included 30-day mortality, acute kidney injury, need for new dialysis, and length of stay. And they found that these outcomes were similar in both groups. They did not find that Ringer's lactate had any edge over normal saline in pediatric patients. And also in this particular study, what they found was that the Ringer's lactate was preferentially used by clinicians as first line in patients who had lower severity of illness. So when they had this head-to-head comparison, obviously this is an observational study, they found that both were almost similar as far as children were concerned. In another study which was published in Critical Care Medicine, however, it showed contrasting results. It showed lower mortality, lower kidney injury, and fewer vasoactive infusion days in children where balanced crystalloids were used. So what does the Surviving Sepsis Campaign 2020 say about the status of balanced versus unbalanced crystalloids if we have to select one to treat our patients with septic shock? So it's very clear, the recommendation, it says pending further high quality pediatric data. I think we need to remember that we suggest, the SCC recommendations say they suggest that balanced crystalloids could be preferred to normal saline for resuscitation in children, provided there are no other contraindications to the use of an alternative type of fluid. For example, if there is hyponatremia, then one would prefer to use saline, or let's say that there is a concern for increased intracranial pressure, you would prefer to use saline. If you don't have these kind of settings, then they suggest that we may use balanced crystalloids instead of normal saline in resuscitation of children with septic shock. However, they conclude in the recommendation, which is important for us, that the grade of recommendation is weak and it is very low quality evidence. So to summarize the points in resuscitation phase, the triggers for fluid bolus have to be specific. Tissue hypoperfusion is key. We always use isotonic fluids. Volume and rate of administration depends on the setting, that is resource limited versus advanced setting, clinical parameters, coexisting comorbidities like anemia and malnutrition. Remember that we may normalize the macrocirculatory numbers, that is the hemodynamic variables, but how the microcirculation is going to behave is something which is not completely under our control. Respiratory worsening should be anticipated and mitigated by prompt respiratory support. And balanced fluids are coming up in a big way. More data is needed. Cost can be a major concern, especially in resource limited setting. And colloids, the consensus is, are not used in most situations. Now coming to the same Master M, as he progresses, he required 3 normal saline fluid boluses during the resuscitation phase, about 15 to 20 ml per kg, which was given over 15 to 30 minutes, followed by epinephrine, which was started at 0.2 mics per kg per minute. So what did the therapeutic endpoint show? There was tachycardia still, the respiratory rate was higher, the central pulses were palpable, the peripheral pulses were feeble, BP was 78, marginal improvement. CFT was still prolonged. Urine output was still low. The third spacing in this child was making the tissues look turgid. So the resident at bedside was confused whether the child is fluid overloaded. And as I said, the microcirculation and macrocirculation need not necessarily go hand in hand. So there was a lactate elevation, which was evident on ABG. So what do we have? We have a child whose therapeutic endpoints are not fully met. So the question that comes to our mind, should we give more fluids or should we escalate the vasoactive therapy? How do we decide this? So then we come to O of the Rose concept, which is the optimization phase. Here, the second hit is because of the reperfusion that you have done during the first phase. There will be flow that is established, and the injury that is caused in the tissues due to the second hit is usually the ischemia reperfusion injury. You're always confused whether we have to give more fluids or not to give fluids, and what is the risk. So it is very important in this particular stage to assess whether a child is going to respond to fluid or not, what we call as fluid responsiveness. And we have to individualize based on whatever are the needs of a given child and target the organ perfusion. So what happens? So to understand what is fluid responsiveness for the optimization phase, it is important for us to understand what happens to the fluid that we give during the first phase. So as this diagram beautifully shows, that as the time elapses from 0 to 5 to 1 hour, you see that less than 5% of the crystalloid that we have pushed during the resuscitation phase remains in the intravascular space at the end of 1 hour. So it seeps out. That's why we saw that colloids tend to do better. And the stroke volume as well as the map returns to baseline. That means again, there will be a need to push more fluids. So what happens to this fluid? The fluid seeps into the interstitial compartment and results in tissue edema, which in this particular child was noted as a turgid tissue, but that's not because of an intravascular fluid overload, but it's more because of an interstitial fluid compartment, which is overloaded because of this leaking. So we have to remember that in all sick children, we swing between two extremes. The one extreme is hypovolemia, where the patient has reduced tissue perfusion, and the other extreme is the hypervolemia, where the patient may go into edema, intra-abdominal hypertension, pulmonary edema, and all kinds of organ dysfunction. And it's important for us as clinicians to maintain our patient somewhere in this particular, the nadir or the lower end of this inverted parabolic curve. So we have to remember that not all patients are going to respond to whatever fluid bolus you are going to push. In fact, it has been shown that only 50% of the patients are fluid responsive. In the rest, if you push fluids, you are only going to cause more organ dysfunction. So what is this? What makes fluid work? So we are all fully aware of the Frank-Stallings curve. where the ventricles, if they are in the ascending limb of the Frank-Starling's curve, to simply put, what it means is that if you give fluid or preload, you stretch the ventricular muscles, and once you stretch, the stroke volume will increase. If the ventricles are in the ascending limb of the Frank-Starling's curve, your patient is going to respond to fluids. If the patient is not in the ascending limb, whatever fluid you give, the ventricles will fail, and the patient will not be able to increase the cardiac output. This is one. Second important thing what we need to remember, as I said, I think the most important crux for all of us to remember is that fluid needs are very dynamic. So if you look at this particular graph from 0 hours to 8 hours, you see that dark blue component of the bar graphs, 57, 22, 11, 10, and 3. So this means that at 0 hours, 57% patients were responding to fluids, but by 8 hours, only 3% patients are responding to fluids. So what this means for us clinically is that as the hours of the disease progress, the fluid responsiveness also decreases. So the later the patient comes to you, the decompensated the patient comes to you, it's less likely that the patient is going to respond to fluids. So we can't push fluids like what we would have done in the resuscitation phase. So we are all aware of the static and dynamic parameters which we use to measure the fluid responsiveness. I will not be going into the details because this is outside the purview of this talk and I wouldn't have time to complete the rest of the things. But the static parameters by convention is the CVP, which all of us, like when I was a resident, we had all given fluids based on CVP. But now the static parameters are kind of relegated to the background. Nobody follows them much. Everybody relies on the dynamic parameters where you see what is happening. It reflects the patient status on the Frank-Starling's curve. It reflects the phasic changes which are occurring. But one must remember that these may be very different in a child who's breathing spontaneously and a child who's mechanically ventilated. I think the IVC diameter measurement is something that all intensivists, I think, are very familiar, and probably the point of care ultrasound has changed the way we look at fluid responsiveness and push fluids in patients. So we look at two indices. One is the collapsibility if a patient is spontaneously breathing, and other is the distensibility index if the patient is on mechanical ventilator. So the key points in the optimization phase are: once you have resuscitated, do not push fluids blindly if the therapeutic endpoints of shock are not still fully achieved. More than half may be still fluid unresponsive. Individualize the needs. Look at predictors of fluid responsiveness, whatever is available in your setup. And also, it is recommended that we use early vasopressors to recruit blood from the venous pool and waiting to start vasopressors. The previous teaching, conventional teaching or traditional teaching used to be fill the tank first and then start the vasopressors. There is a little change in this conceptual thinking. You start vasopressors, don't wait for fluid resuscitation to complete, because vasopressors basically by constricting, they recruit more blood from the venous circulation. So now let us come to Master M again. Let us see what happens further to this child. So based on the point of care ultrasound, this child required 2 more normal saline boluses. So he was found to be fluid responsive. So he was given 2 more boluses based on the IVC collapsibility. Tachycardia reduced, respiratory rate reduced, central and peripheral pulses became well palpable, BP improved, CFT also improved, and he started producing urine at 1.5 ml per kg per hour. Mentation became normal and lactate clearance was achieved and lactate fell to 1. So the therapeutic endpoints of shock were achieved. So now we need to maintain this child on some kind of fluid therapy. So we go on to the next phase, which is the maintenance phase. So there comes the S of the Rose concept, which is the stabilization phase, where the primary objective is to replace the ongoing and insensible losses in a child who has just recovered from resuscitation and optimization phase. Again, based on the individual needs, you target a normal organ function, and our goal is to achieve a 0 to a negative fluid balance. You don't want the tissues to get turgid, and this will take days. It can't be a few hours like what, or minutes like what we saw in the previous 2 phases. Here comes the importance of how we calculate the maintenance fluid. We have all grown up looking at this study, which was published in 1957 by Holiday and Segar. And I think all of us as residents, especially the older people, we have all calculated fluids in all our pediatric patients using this particular table, where the maintenance needs was based on the calorie that was expended by the child. So what was the problem with this Holiday-Segar formula? That there were a lot of criticism in the last 3 to 4 decades with this Holiday-Segar formula. The main, as you can see in this particular graph, there is a basal metabolic rate, and the top curve shows the estimated total expenditure with normal activity. And the middle curve is the one which is basically a computed graph. So what it means is that the calculations are basically computed from what happens in healthy children. So they cannot be verbatim extrapolated to acutely sick children because they have very differing physiology. And the estimated energy expenditure based on body weight is highly unreliable. These were the critics of the Holiday-Segar formula who said that these are the problems with the calculation by Holiday-Segar. And we all know that there is an impaired excretion of free water in all sick children because of SIADH. And also sick children generate electrolyte-free water by the kidneys. So if we use the Holiday-Segar formula in sick children, we will end up overestimating the fluid needs. We all know the composition of the commonly used fluid, but I would just like to draw your attention to the second in the row, which is the isolite P, which we have commonly used as maintenance fluid, where you can see that it has so much of electrolyte-free water. So basically, when we give 0.2% saline with 5% dextrose, we are actually adding lots of electrolyte-free water to the patient. So what happens in a sick child? Already there is SIADH, free water retention is there. There is less calorie expenditure because the child is hospitalized, maybe on ventilator. The ventilator has taken over the breathing. So by Holiday-Segar, we are overestimating the intake. Along with this, the kidneys are producing solute diuresis and retaining more electrolyte-free water. There would be some alteration in the sodium-potassium pump, and there may be intracellular translocation of sodium. And over and above, we give hypotonic fluids or isolite P to such a critically ill child, we are only going to end up causing more dilutional hyponatremia. And that's exactly what happened. And there are several studies which have shown, and this table basically shows so many studies which have clearly shown that hyponatremia is a real problem when you use hypotonic fluids in critically ill patients. So then the question is, isotonic fluids, is it a better and a safer alternative? We are very sure that hypotonic fluids are not to be used. So then should we use normal saline or isotonic fluids? Because they are more physiological and they will tend to maintain tonicity, especially in a critically ill child where there are so many factors which are resulting in retention of electrolyte-free water. So what is the evidence? This is an evidence-based era, so we just can't leave things by saying that, yes, this happens. So there are many studies started right from 2006, 2007. So there has been a lot of body of work on this isotonic versus hypotonic fluids as maintenance. And clearly everybody has shown that hypotonic fluid increases hyponatremia. At the same time, most of these studies have also concluded that isotonic fluids do not increase the incidence of dysnatremia, because the major concern for people who still did not believe, especially the Holiday-Segar group, they said that no, if you give too much isotonic fluid, we are going to make the patient hypernatremic. But most studies have shown that that does not happen. And the most recent evidence, which is a meta-analysis of RCTs, especially in children, this was published in 2021, assessing the safety and efficacy of isotonic versus hypotonic fluids in hospitalized children, 22 RCTs, almost 4,000 participants, both surgical and medical. What they found clearly was that hypotonic fluid significantly increases the risk of hyponatremia, both less than 24 hours as well as more than 24 hours. So I think once for all, the debate is settled. There is no question about using hypotonic fluids as maintenance fluids in sick patients and especially post-operative patients. And they did find that isotonic fluid increases the risk of hypernatremia in less than 24 hours, but no other significant adverse outcomes, no mortality difference. And therefore, they concluded in this meta-analysis clearly in pediatric patients that isotonic fluids are protective against hyponatremia, while hypotonic solution increases the risk of hyponatremia. So I think this is one facet which has been settled once for all. So some of the safety concerns which stays with isotonic saline, other than I don't think hypernatremia is so much of a concern, but I think the one which is going to come up in a big way and we all are going to be concerned is the incidence of hyperchloremic metabolic acidosis, which we talked about during the balanced fluids. And there may be gross overload in patients where there may be, depending on the underlying clinical state. So the key points, the stabilization phase where we are going to use maintenance fluids. Children with acute illness have impaired free water excretion. Hypotonic fluids should not be used because they definitely cause hospital-acquired hyponatremia. Isotonic fluids are more physiological. They do not increase the risk of dysnatremias, but we need to watch out for the occurrence of hyperchloremic metabolic acidosis and fluid overload, especially if we are going to use them for a continued period of time. So coming to the last phase for Master M, that was day 4 of PICU stay. The child was started on maintenance with 80% maintenance. Child was on ventilator. The edema was increasing. Sodium was reducing. Urea creatinine was within normal limits. On day 5, the team felt that the ventilatory requirement has increased. The edema has also increased. And there is a slight increase in the urea and the creatinine. So it's very clear that there are signs of fluid overload that are coming. Worsening ventilatory parameters, some AKI which is worsening. So the next phase of fluid therapy in all sick children, if they are not able to excrete whatever they have taken in during all these 3 phases, we have to facilitate fluid removal. So this is what is called the E of the Rose concept, which is the evacuation phase. And in this, the 3rd phase, there is a global permeability syndrome because of which there is interstitial edema. And therefore, this altered permeability causes the fluid to creep into the interstitial space. And this is the classic Starling's model, where we all know that the fluid leaves at the arterial end of the capillary because the hydrostatic pressure is higher than the oncotic pressure, and it enters back into the interstitium from the venous end because the opposite occurs. Now, what happens in sepsis when the glycocalyx of the endothelium is ruptured or becomes faulty? Then there is leakage of this fluid into the interstitium, and this causes interstitial edema. The other concept that all of us need to remember, because we keep charting fluids for patency of IV line, for giving some drugs, for giving concentrated electrolytes. So this is what is called as a fluid creep. It's basically the volume of fluids which is non-resuscitative volume that has gone into the patient. So you see in this wheel diagram, the yellow component is the fluid creep. It constitutes almost 32.6%. This was a retrospective study done in Belgium. So it's a huge chunk of fluid that we are pushing into critically ill patients is because of the fluid creep. And the other interesting concept is that this fluid creep increases as the patient's day in the PICU increases. So by day 4, day 5, the fluid creep really increases. And this is clearly associated with organ dysfunction, sodium problems, and all electrolyte disturbances. And in fact, in the non-resuscitation fluid excess in one of the study, it also showed that it was associated with higher hospital mortality, though these 2 studies did not show whether there was a causal association, but there was an association which they demonstrated between fluid overload and bad outcomes in critically ill patients. So it's important for us to remove this excess fluid or dry the patient, what the intensivists call, which you can do by using diuretic infusions, or sometimes they may need therapies like ultrafiltration. Now, this concept of microcirculation, if you see this particular diagram, this is an interesting concept. Whenever there is interstitial edema, the diffusion distance increases. So you need to recruit these smaller vessels. So many times when you use diuretics, you will be decreasing the interstitial edema and recruiting these vessels. So from all these 4 phases, it's very clear that fluid in critically ill is a very tightrope walk. It's not easy at all. If you give less fluids, you're going to cause hypoxia and hypoperfusion. If you give more fluids, you're going to cause tissue edema. So therefore, just like we do for antibiotics, it's important that we follow a fluid stewardship principle of what is called as the 4 Ds. It's the drug, which fluid, and what situation, what is the dose, what is the duration, and we need to de-escalate as soon as we know that we don't need to give fluids further to the patient. So does one size fit all? Definitely not. We need to see the clinical indication, goal in each scenario. We know that restricted volume, maintained tonicity, isotonic is more physiological, and monitor variables like input, output, and electrolytes at regular intervals so that you can change your prescription based on these parameters. So where do we use isotonic fluids? Anywhere, any clinical indication where you have higher effective osmolality needs to be maintained. For example, raised ICP. or where you want to like maintenance fluids where there is electrolyte free water excess, hypovolemic states, or any post-operative setting, because all this debate about hyponatremia came up first from the post-operative patients. Where would you use fluid and sodium in a restricted manner? Obviously, in edematous states and oliguric states, you would like to use a restricted sodium as well as fluid. The typical example is our acute kidney injury, where you can go with the 400 to 600 ml per meter square. Indications for using hypotonic fluids. So I talked so much about hypotonic fluids causing hyponatremia. So does that mean that we throw away the hypotonic fluids? No, it doesn't mean that. It means still some situations where there is a pure free water deficit causing hypernatremia, or there is a renal concentrating defect, an nephrogenic DI-like picture, or there is some condition where there is an extrarenal free water loss, for example, burns in neonates, fever, infectious diarrhea. You'd still need to use hypotonic fluids because you can't give too much sodium to such a patient. And some disease specific fluid prescription for all pediatricians, any CNS illness, it's very important for us to first start 100% maintenance, because a good systemic perfusion is important for a good cerebral perfusion. So don't start restricting straight away. Titrate according to input output and sodium. If you find that the sodium is falling and there is clear evidence of SIADH, then you can go for restricted fluid. Simple respiratory illnesses like asthma and bronchiolitis have SIADH. So generally we start with 80% maintenance fluid. For congestive heart failure and acute myocarditis, you start with very restricted volumes, maybe 40 to 50% to begin with, and then titrate the parameters as I explained. And sometimes they may have associated sepsis or diarrhea, they may require more fluids. Nephrotic syndrome is a very tricky situation because there is a relative intravascular hypovolemia, but the child looks very edematous. So you may start with maintenance fluids and need to closely monitor the patients. And this is one condition where you may need to think for early colloids because the albumin is quite low in such patients. So the key messages, I hope I have not overshot the time. No single IV fluid composition or rate is ideal for all children. So this is very clear that one size does not fit all. We follow the 4 Ds for fluid therapy, very similar to what we do for antibiotics. So we need to discipline ourselves as far as fluids are concerned. Isotonic fluid always, if you're thinking of volume resuscitation or R of the Rose concept. We need more answers on balanced fluids, but it seems that it may be a very promising option for us. Hypotonic fluids no longer recommended for maintenance due to risk of hyponatremia. This debate is settled. Post resuscitation, one needs to be conservative with fluid strategy to minimize fluid overload and organ dysfunction. So keep looking for early fluid removal strategies so that you can salvage the organ systems. It's very important for us to maintain a fluid balance. I know it's easier said than done, but it is something that one has to keep titrating at bedside. And a big thank you to the team from Dubai, from my team, Pikku from PGIMR Chandigarh. Thank you once again for the opportunity given.
Thank you very much, Professor Jayashree, for this wonderful presentation. I'm sure all viewers have enjoyed. I'm sure there will be a lot of questions. Now I'd like to request Dr. Monica, Senior Consultant Neonatologist and Medical Director of the Emirates Specialty Hospital, to start the talk. Dr. Monica is going to tell us about the special situation in premature and full-term sick neonates. Dr. Monica, please.
Yeah, thank you very much. It was a wonderful listening to you, ma'am, as usual. So I'll just be talking basically basics of fundamentals of fluid and electrolyte in neonates, because they are quite different from children and adults. And our physiology is different, and we are not very much equipped for our newborns to cause if any balance occurs. So we are much more fragile than even children. Excess fluid will cause CCF, dyselectrolytemia, edema, and we also have a risk of PDA, NEC, BPD, and death. And if we go down less fluids, we may cause dehydration, shock, renal failure, dyselectrolytemia, metabolic acidosis, and even increase in jaundice. And later on, we may have a postnatal weight loss. So we want to maintain fluid and electrolyte. And a very peculiar thing which happens in our newborn is that we have to allow a postnatal physiological weight loss without compromising the intravascular volume or cardiovascular status. And then after 1 to 2 weeks, we want us to babies to gain weight. So how our babies are different from children and adults? It's because our babies are born with a lot of total body water and extracellular fluids as compared to children. And then in that also, our term babies are different from preterm babies. So we can see that smaller the baby, the total body water is much higher, and a term baby has little less total body water, and the fat is much lesser in our premature babies. And hence, in term as well as preterm, there is a postnatal weight loss, which is because of increase in the capillary integrity, absorption of the fluid into intravascular, and because there is an increase of blood volume, it releases ANP and it causes diuresis. So we have to lose this extracellular fluid, primarily interstitial fluid. And this loss is almost 5 to 10% in term and 10 to 20% in preterm, which happens physically. And if we don't allow this to happen, we may land up in PDA, neck and BPD, and even death. I'm not going through this, but we have a phase of adaptation. So that's why each day is different for our babies. There is a pre-diuretic phase where sodium, potassium excretion and water balance is quite less. Diuretic phase, which when it abruptly increases, and then comes the homeostatic phase. So only in the homeostatic phase, the things will depend on what we are giving. But before that, it may be quite different. And our babies have a low GFR. They're even concentrating capacity is a problem. So they may have a urine output, but they may be in dehydration. So the sodium reabsorptive capacity of the nephron is quite limited in our babies. And so we may land up in hyponatremia very often. Even our babies have limited potassium excretion. So insensible water loss, when we talk about it, is through the skin 2/3 and respiration 1/3. And these are the major consideration when we talk about fluid and electrolyte therapy for extremely preterm newborns. And it is the most variable thing. So you can see 25 to 27 weeker in first few days. The insensible water loss may go up to 57 to 214 ml per kg per day. And in term, it is only 8 to 18 ml per kg per day. At day 7, it does decrease in even preterm babies to 31 to 68. And if we look at the balance, it may be 82 ml per kg for 750 to 1000 and much more in lesser babies. And for more than 1500 gram, it is just 26 ml per kg per day. So this is because we have a very small stratum corneum, and we might actually peel off the skin and cause more problems. So if you look at the transepidermal water loss in a 22 to 23 weeker, it is very high in the first day, but it comes down to 40% in by first week. And in 24-25 weeker, it is much lesser than 22 weeker. And it also comes down by first week. So we have to be very careful when we are giving charting fluid due to this. Now, what are the other factors which may cause insensible water loss? Respiratory distress, environmental temperature more, or baby's temperature goes more, baby is crying. If there is a skin breakdown, if you're using the warmer for a preterm baby, the water loss may increase by 50%. Phototherapy may increase the water loss by 50%. So our main goal is to reduce this insensible water loss by using incubators, using plastic barriers, plexiglass heat shields, humidifying the gases, prevent skin injury, and applying oil or ointment, especially the coconut oil is very useful. So we don't want to actually replace the insensible water loss, we want to prevent it. So for preventing, we are either using humidified incubator or a warmer. We all can see that warmer still has a very higher insensible water loss as compared to the incubator. But the humidification itself has a problem. We cannot see the baby. There may be a problem with the increased growth of bacteria. And a very beautiful thing which has come up in a new research is that the radiant warmer, when we use, it causes a more rapid barrier formation and the skin gets more maturer. So still we use humidification high in the first few days, and we come down by 1 week because we can understand the insensible water loss is much less after 1 week. So we do not continue to give high humidity. Now, once we know the physiological weight loss, neonatal handicaps, Let's discuss the actual fluid requirement. So total fluid requirement we calculate by maintenance plus deficit plus ongoing losses. And maintenance comes with insensible water loss, sensible water loss, which is urine and stool, and tissue growth. So if we calculate, I'm just giving example of day 1. Term baby insensible water is less 20 ml per kg, preterm is more 60 ml per kg. And urine is required 50 ml because in term 15 milliosmol with urine concentration of 300, this much urine is required. No stool, no growth, so 0, 0. And there is a negative water balance for the weight loss, -10 and -20. So net fluid requirement is 60 and 80. So to begin with, we start 60 and 80 in a preterm and a term, but in a very small baby, we may have to go higher, and we may have to advance by a strict hydration status to be seen. Otherwise, we are just increasing 20 ml per kg every day, which takes care of the fecal losses and the tissue growth and the requirement. And we reach 150 ml in 1 to 1.5 by day 5 and 150 on day 6 or on a term baby. So by day 6, their fluid requirement is almost similar. Having said that, different units are doing different, and controversy persists. Iowa, Japan, and Sweden, they have a very varied therapy. They are giving up to 250 to 350 ml per kg and taking the baby in the radiant warmer. This is 50 to 60, very restricted, and 80 to 100, a medium. And all of them, I would say, are saving 22 weaker babies. So you should know what you are doing by looking at the physiology and looking at the baby. Electrolytes, we don't start early, as ma'am had already said, that we don't give this to preterm babies and even the term. We should have a weight loss of 6% when we start. For term, we start at 2, and for preterm, little higher. And as the weeks progress, we need to increase to 3 to 5 milligram per kg per day. Potassium, we start only when we have a urine output of more than 1 ml per kg per hour, and serum potassium has gone down to less than 5. And the dose is 2 for both. And all the babies would require glucose. So to begin with, we start 10% dextrose for more than 1250 and 5% dextrose for less than 1250 grams. And we monitor weight, urine output, specific gravity, serum glucose, sodium, potassium, burn, creatinine, and blood gas. So this is very important. Rules of correct charting is that all calculations should be based on the birth weight till it exceeds, and it has to be the first fluid you have to initiate, but later on you have to be strictly following according to the monitoring. Do not forget to adjust drug, feed, blood products, inotropes, or whatever extra you're giving, because this, as ma'am already said, are the creepers which will increase the fluid overload. And write neatly, use calculator, show all steps of calculation, and always see what GIR the baby last got so that we know we are giving a right dextrose. Infusion pump should be used, and if not available, then only micro drip set. And a sick newborn may require 4-hourly, 6-hourly chart, a well baby 24-hourly. So we have to create a balance looking at what we have to replace and what the baby got extra and minus it. For example, this baby at 3 kg on day 7 required this much volume of fluid, but losses we have to see because it's under the radiant warmer. So 20 ml per kg we have to deduct, add more because this is the loss. However, the baby is getting vancomycin and other thing by 90 ml of saline, that don't forget to deduct. So the actual volume will be different, which should be calculated properly. How do you replace fluid deficit? IV fluid should be increased if you have a more weight loss of 3% or more, or a cumulative weight loss of more than 20%. Your sodium levels are increasing, your specific gravity is increasing, your osmolality of the urine is increasing, and urine output has gone down. However, you have to restrict your fluid if your weight loss is less, because you are expecting a weight loss, and there is a weight gain with sodium being less, or your urine specific gravity is going down and osmolality is going down and urine output is going high. Because I said urine, it will depend on how much you are pushing. So this is what I would like to say in a normal baby. I think we'll take up in questions about our sick babies. How do we handle them?
Thank you very much. Thank you very much, Dr. Monica, for excellent presentation and finishing in time. Now I would like to request panelists, Professor Jayashri, Dr. Monica, Dr. Entesar, the pediatric consultant pediatric nephrologist from Al-Jalila Hospital and the Zulekha Hospital, and Dr. Deepika, consultant intensivist from Menipsi Royal Hospital, our moderator, Dr. Sunil, consultant intensivist from Mediclinic City Hospital, Dr. Diari, chairman of academic affairs, and Dr. Kalpana, the secretary of the club. Over to Dr. Kalpana, please start the session. Dr. Diari, please join. Over to Dr. Kalpana.
Yes, Doctor. Thank you, Dr. Jayashri and Dr. Monica for this wonderful talks. A lot has been said and a lot needs to be clarified, so we will do that in panel discussion. We are getting a lot of questions from the audience as well. So I will request Dr. Sunil to start with the first question.
Thanks, Kalpana. At the outset, and Dr. Saurabh, Jayasri and Monica, it was a very interesting start to this discussion. This is a very huge topic, but we have a few questions to check further about certain situations. And there are more than 650 participants who are around at this point of time, and there are quite a lot of questions coming as well. So some of the questions are, in term babies with asphyxia, how it is different in management of the fluid balance and what precautions are to be taken. Dr. Monica, would you like to take it?
Yeah. So this is very important because we have asphyxiated babies, and these are different from a term baby. And if you know, asphyxia, mainly they have whenever baby gets asphyxiated, the arginine vasopressin is released. And because of the release of arginine vasopressin, SIDH, like a picture, is what we see. And this causes cerebral edema. And in this case, usually for the first 48 to 72 hours, there is a high chance of baby to have seizures because of this issue. And that's why we try to actually monitor the baby very closely and give the fluid restricted. Now, when we have SIDH like picture, where we know that the hyponatremia is there, edema is there, we would like to restrict the fluid, and we go down to, like, if we are on day 1, we might go down to 40 ml per kg instead of 60 ml per kg only in this situation. And like 2/3 of the fluid we are going to give till the hyponatremia gets better. So once the hyponatremia, which will be better by day 3, then we will go back to the normal levels. Another very peculiar things which can happen in our baby who are asphyxiated, because the kidney gets damaged, because the perfusion wants to go to the brain and the other important organs. So kidney gets sometimes affected, and you may have a picture like a acute tubular necrosis, where you will have like a oliguria and you will have like a total renal failure. Now, in this case, you will like to restrict the fluid more, which will be like you will give only for the insensible water loss, and you will be giving for the metabolic water requirement, which is only 400 ml per meter square. But to be simple, we calculate by 40 ml per kg. So we give 40 ml per kg plus the insensible water loss. And if the baby starts passing urine, then we add more of fluid depending on what's happening. So these are the two different kind of fluid management which we have to do in our asphyxiated babies. And we are always looking into the intravascular volume. We are doing point of care ultrasound for all such sick babies, and we are looking at the IVC collapsibility to see how much fluid to be given. So sometimes you have asphyxiated baby, but it is edematous, and the edema is not due to, it is due to third space interstitial edema, but the intravascular volume is compromised. Then we will actually titrate the fluid accordingly. We will not restrict at that.
Thank you. These are the general principles guiding us. But obviously, in case of severely asphyxiated babies, you will be concentrating on them more than mildly asphyxiated babies, of course. At what point of time you would like to start feeds on them? And will you still receive the
Asphyxiated baby,
feeds?
you mean?
Yeah.
So usually, when we have asphyxia, we have hypothermia treatment, which we are going to follow. So we are going to put the baby in the hypothermia, where we will give 32 to 34 degrees centigrade temperature will be given to these kind of babies. So whenever you have given already, baby is asphyxiated, again, your intestine is the one which is getting skin and intestine the blood perfusion goes away from there. So it is already getting compromised. Plus also you are putting hypothermia, so it gets more further compromised. So we don't give full feed to these babies, and we don't want to keep them NPO because we don't want the intestine villi to get compromised permanently. So what we do is we give little feed, that is around 20 ml per kg or 30 ml per kg, like that, for till the time 72 hours where we are giving hypothermia treatment. And then once the hypothermia treatment is taken out, then we start giving full feed if the baby is fine.
Thank you very much. That is very much in detail. Maybe you can take up the next question as well. In situations like respiratory distress syndrome, bronchopulmonary dysplasia, and PDA, what are the principles guiding fluid management in these children? Neonate.
So if you have RDS, what happens in RDS is that there will be hypoxia. So whenever you have hypoxia, there may be a compromise in the renal functions. Then you are putting these babies on ventilator. So ventilator, when you're putting, there will be aldosterone and ADH, which will be secreted because of that. And this will cause water retention. So that means we are going towards the level of fluid overload. And already your lungs are compromised. So when you do fluid overload, you will increase the ventilatory requirement of this baby. And hence, the role comes of a fluid restriction in these babies. Again, I would say that whenever, don't go blindly with fluid restriction, please look at the intravascular volume. And that's why we are going again and again on point of care ultrasound to look at what is happening. Even if you do a eyeballing and see what is happening to your ventricles, what is happening to your IVC, you can know that. Now, what happens is that in VPD, when you are already VPD set in, here, of course, your already lungs are in a very bad state. So here you have to restrict the fluid, and you cannot go beyond 120 to 130 ml per kg per day, whereas normally you give 150 ml per kg per day. And having said that, we have to really make sure that our nutrition is not compromised when you are actually restricting your fluid to 120 ml per kg. So you have to increase your calories by adding more, like human milk fortifier, or you can add, more proteins or fat to these babies to get more calories. These babies require around 130 to 150 calories per kg per day, and you're restricting the fluid. So you have to create a balance, which is very important.
Thanks, Dr. Monica.
Same with an PDA. PDA also, you need to restrict your fluid.
Dr. Kalpana, do you want to take
Yes.
it further?
Yes, I think there are a lot of questions to Dr. Jayashree pointing to the same thing, whether the recommendations that you have given regarding fluid therapy, they apply only to critically ill children, or they would also be the same for regular children who are taking treatment in the wards and require IV fluid therapy. So.
Thank you, Dr. Kalpana. So the recommendations which I talked about for maintenance fluids, that applies for both critically ill patients, post-operative patients, and children in wards who are receiving maintenance fluid. So any child who is hospitalized, I think I saw one question in the QA box where somebody has asked that why there is hyponatremia in children, sick children or hospitalized children. So I did mention all the factors, but just to reiterate for that question, one, of course, is SIADH, which is a predominant factor. So there is an inappropriate secretion of ADH, as a result of which water will be retained. So this will be an electrolyte-free water. And second would be that the calorie expenditure or whatever expenditure that the child is supposed to do otherwise is not doing because the child is hospitalized. So if we calculate our maintenance fluids according to our traditional holiday SEGAR formula, we will overestimate the needs. because though that formula is based on how much calories expended. So we know that any child who's hospitalized is not going to expend so much calories. And third is that sick children, they tend to have a solute diuresis, meaning thereby that they excrete more solute, and that's retain more water and excrete more solute. So again, this concept is called generation of electrolyte free water by the kidneys. So because of these 3-4 factors, and if over and above this we give, let's say, hypotonic fluids, we are basically causing dilution, and this dilution causes hyponatremia. So hyponatremia is basically seen in most of the sick children. It's not necessary that only ICU children, but they can be seen even in post-operative children or children who are admitted in hospitals where we use IV fluids. So the maintenance fluid, what I talked about, the evidence, and what that applies to all patients who receive IV fluids in hospital.
Okay, so as we know, prevention is better than cure, but suppose a child develops hyponatremia while we are treating them. I would probably pose this question to Dr. Deepika. How do you go about assessing or treating hyponatremia, symptomatic hyponatremia?
So yeah, so like you said, that hyponatremia, you qualified already as symptomatic, but most often what happens is that even in ward patients, sometimes we don't even notice. The sodium may be like 128, 129, and child will be otherwise fine. So those are the things we actually don't, worry too much about that. But having said that, if we don't monitor sodium frequently, don't monitor the intake output, it can go down much, much further. It can really become 124, 125. Now that's when they start becoming symptomatic. The most severe form of symptomatic hyponatremia is if a child becomes very drowsy or has seizures or something like that. But even before that develops, they may sometimes have mild headache, they may have vomiting. So that also qualifies for symptomatic hyponatremia. So what we need to do when acutely, if a patient has a low, like a drop in sensorium or seizures, then we need to treat it with hypertonic saline. That it just shows that it has developed so rapidly that the brain cells are swollen and intracranial pressure is high. So that's when for the symptomatic hyponatremia, we need to give hypertonic saline to increase the sodium level maybe by around 4 to 5 millikelens a little rapidly. Beyond that, we need to monitor the sodium a little more closely, every few hours, and then decide about the rate of hypertonic saline. First is a bolus, about 3 to 4 ml per kg we give. It will increase the sodium by 4, and then subsequently may need a continuous infusion. In addition, if we have to see the fluid balance, he should not be fluid overloaded, and we have to, try to keep them a little bit negative. That's just for symptomatic hyponatremia. Yeah.
Right.
Can I say something, Doctor? Because our newborns have a different kind of issue. Like acute stage, whatever she said is what's happening, and we are giving 6 ml per kg if they have seizures and less than 124. And after that we don't allow it to go very fast, and we go slow over 48 hours or so. But what happens very frequently, which most of us should know, that when we have a preemie who is growing and then he doesn't grow, there is a faulty growing after some time, we must always look at sodium, because the kidneys are so immature that they are losing sodium from the kidneys, and just by looking at the sodium at that point of time, we just giving we don't give IV that time, we just give oral extra supplement of sodium, the baby will start gaining weight. So they behave little differently in the acute and the later stages. So I just wanted to
Sure. Yeah. Thanks. Yeah.
Thank you. Jayashree, you have put down the stage very well for use of isotonic fluids for resuscitation and maintenance afterwards, but it is really heartening to see usage of 1/5 normal saline fluids in children. It is deplorable, and the practice has to change, but still it continues to be as one of the practice that has to change. One comment from and one question to Jayashree is about management of persisting metabolic acidosis, hyperchloremic metabolic acidosis.
Okay. So if we are like, let's say there is a child with septic shock, similar to the case scenario that I presented, then initially the metabolic acidosis would be a high anion gap metabolic acidosis because of poor tissue perfusion, hypotension, and shock. So we need to approach with our isotonic crystalloids and keep resuscitating the patient as whatever was explained. But if at some point we find that the acidosis persists, the anion gap has closed, the chloride load is increasing, slowly the chloride is creeping up. So basically what has happened over the course of treatment is that a high anion gap acidosis has been converted into a normal anion gap acidosis. And that is because of the high chloride, which probably has been contributed by the normal saline to some extent, and there may be an associated acute kidney injury because of the perfusion problems. So in this scenario, continuing with normal saline may not be a good option for us because the chloride load is going to increase. So we can switch to balanced crystalloids. So balanced crystalloids are not only used for resuscitation, they are also used for maintenance. So there we need to decide whether we need to give Ringer's lactate, which is also a balanced crystalloid, or maybe go for plasmalide, depending on what is the availability. So again, there was a question in the chat box which said that is it important for us to keep monitor the ABG and then decide which fluid to use? I don't think initially we should have any confusion about what to use. Initially, we can go with our isotonic saline. But if there is a persistent acidosis and severe hyperchloremia, then obviously in that particular situation, it will be difficult if we keep giving normal saline. So there, maybe we can look at the closure of the anion gap and then decide about switching over to balanced crystalloids based on the availability.
Again, one of the questions in the chat box is about usage of NIRS, and is NIRS monitoring help us in knowing the behavior of microcirculation in resuscitation and in the optimization phase?
Yeah, so and the microcirculation can be there. There are several ways to assess the microcirculation, and one of the modalities is NIRS, that is the near infrared spectroscopy. So the regional perfusion, which is an indirect surrogate of how adequate the microcirculation is, can be assessed by using NIRS. If it is available, we can use the NIRS. For example, if we use NIRS, we can see the renal perfusion, what is happening to the abdominal perfusion. Very similar to what we do when we are assessing in multimodal neuromonitoring, we look at the cerebral perfusion by doing the NIRS monitoring. Similarly, we can also look at regional perfusion with NIRS. It can be done. Microcirculation indirectly can be assessed by an NIRS monitoring.
Is it a part of your regular monitoring, doctor?
We do it for our CNS patients. Definitely, it's a part of regular monitoring for all our CNS neurocritical care multimodal monitoring. NIRS is used routinely in all patients in our, but we don't do it routinely for acute kidney injury or abdominal perfusion or those things. That we are not routinely doing. We did it as a part of a research study where we looked at renal perfusion using the NIRS and correlating it with other parameters.
May I add one thing here? Yeah, NIRS basically, in addition to the neuromonitoring, cardiac surgery, it has a significant role. So it will not help us decide what fluids to use, but it will help us decide whether, as compared to the brain perfusion, how are the other organs, whether abdominal or renal, how well they are getting perfused. So like ma'am said, it's like a regional perfusion indicator, and the gap increasing is much more important than, just one particular number.
Yeah, that is my experience too, Deepika, in cases during cardiac surgery, post-cardiac surgery, and while they are on ECMO, it is for assessing cerebral hypoxia, especially in relation to the somatic perfusion. So that was one of the main indications we were using NIRS for. But I'm glad its use is increasing, and still further usefulness of this methodology has to be known.
Can I also add? Because it's
Yes,
coming
please.
up a big way in our newborn neonatal care. Though our unit is not having NIRS, but we have NIRS in Latifa Hospital, Jalila Hospital, where they are really using it. And Ma'am Intisar, she's here, so she can tell. And we are also looking into, first it started with cerebral only. And then now we are looking into the regional perfusion. Of course, we are not basing our fluid on that, but at least we are able to assess what's happening to the regional perfusion with that. So, and as she said, increased gap is the main thing which we are also looking at. It's still under mode where people are just looking into more, but much more systematic reviews are coming on its use as regional perfusion too.
So coming back to the basics again, you stressed that we should not be using hypotonic solutions. Is this remaining the same for, say, neonates or infants, other than children, of course? So are the recommendations the same, say, for an infant?
So for, as we already talked about, that first 2 days are different, where when you are using only 10% dextrose, so you're already not following that. But after that, when because the transition occurs, and after that, when we are using, we don't use hypotonic solution, and especially if our baby is in shock, or if our baby is in dehydration because of the diarrhea, or if our baby is a surgical baby who's losing fluid, we never go use hypotonic thing. We always go for isotonic solutions. But here in with us, we are when we talk about giving boluses, we are still using normal saline bolus whenever we have a problem with the baby's dehydration or in shock. The only thing we do is that we don't give it very fast. If it is a premature baby, we give over half an hour to 1 hour. And if it is a term baby, then we can give in 5 to 10 minutes.
I would like to interrupt, and with permission of our moderators, most of the commercially available solutions are without potassium. Although we have, half normal saline, full normal saline, 1/5, but there is no potassium. I would like to request you to answer this. What is your recommendation? When, is it fair to give a solution without potassium? When to add potassium? And why these solutions, they don't have potassium commercially available? Hey, Dr. Yashri, please.
Yeah, our practice, Dr. Saurabh, is once the child passes urine and the serum potassium is below 5, ideally 4.5 or so, at that stage, we tend to add a normal quantity of potassium, 2 to 3 milliequivalents per kilo. As it comes as an intravenous preparation, we tend to, either our nurses tend to add in the ICU, or from the pharmacy also they can add to the IV fluids, maintenance IV fluids. As potassium has to be guarded very carefully, so 2 nurses will be checking it, and all these sort of precautions will be taken when it is added. The problem would be, in case you use a potassium-free fluid at some stage and then go on to potassium-containing fluid, and some wastage. It's a wastage also. If it is added and continued afterwards, the potassium requirement of the patient, that would be usful. In conditions
my question
like,
is it safe to continue solution without potassium? Sodium, I'm not discussing, only potassium. To continue without potassium for children.
If the patient is not getting any potassium, probably the serum potassium will be dropping down further and further on continuing on the daily maintenance of potassium-free fluids. So I do feel that just like a normal electrolyte replacement, in the same quantity, potassium should be added. Other speakers can use, project their views.
Can I
comment on that?
Yes, please.
Yeah, please.
Okay, thank you very much. I really enjoyed the session so far. And I was keeping quiet because all the questions got answered. Monica and Kalpana know me very well. I would speak if I don't like. But so far things were really, I think I'm enjoying it myself. So about the potassium, I can't not to speak. So the potassium, I agree with Dr. Sunil that we should not do it as a standard. Again, as the other speaker said correctly, every case is different. So you cannot just say, yeah, for sure, start potassium on this or that. But overall, if a child coming in a shock, so we're talking any stage, infant, neonate, children, coming in a shock state, which you expect a very high chance of renal injury or reduced renal perfusion with the chances of AKI, to play it safe, not to give potassium at the beginning, and you will be monitoring those patients frequently, their electrolytes. Usually the electrolyte disturbance either going high or down, either sodium, potassium, it's us who do it, not the patients. They usually come with most likely a normal electrolytes. What happened over the next 4 hours, it's what we do for the patient and what we cause for the patient to happen. So if a patient on an IV, if a patient coming to an ICU setup, you will have frequent electrolytes, then we're not really worried usually about the hypokalemia. We usually about hyperkalemia. So to play it safe, potassium frequently, checking the electrolytes, and then adding it carefully. And a child coming with an ongoing loss, GI loss, most likely in children, to the word stable, you will always have the privilege of adding the potassium and then removing it. Again, I agree with Dr. Sunil, the cost. Why to start with the potassium and then remove it? To play it safe, you have your labs back, your kidney function is normal, child is passing urine, then safely you can add your maintenance. Very unlikely to go into hypokalemia unless this child is a non-tubular disorder child who always running on hypokalemic anyway. Then those patients, you know that from the beginning you will add higher potassium. And those patients, if not known as labeled as a parter, for example, they will declare themselves, let's say, with time. Yeah, that's it.
I also would like to add one more point here. Is that if a child comes to ICU, since I'm an intensivist, I'm talking from that point of view, the potassium, whenever we decide to add based on the electrolytes, has to be added in the maintenance fluid and never in the resuscitation fluid. Whether we're using normal saline or whatever, no potassium should be added in the fluid that is used as a replacement or resuscitation. Because eventually we are going to use large volumes of the fluid for resuscitation. And if there is potassium added in that, it can cause hyperkalemia. So the maintenance amount of potassium should be added in the fluid that we are using as a maintenance therapy, not as a resuscitation or replacement. That's my take on that.
And just a small addition, if I may. The Ringer's lactate contains potassium.
Yeah. Yes. Small.
So we have to be careful, especially when we are selecting a resuscitation fluid and we are not sure about the urine output and the potassium status. It would be safer still to go for normal saline rather than picking up Ringer's lactate. I think it contains 4 or 5 milliequivalents per liter of potassium.
Yeah.
Sure. And about our newborn, can I say something
Yeah.
about potassium? Because I already talked that we don't give potassium and sodium for first few days till the urine output is more than 1 ml per kg and the potassium goes below 5. Then only we start adding potassium. And we never ever give to any newborn fluid which is already pre-made. We are always monitoring and making our own fluid. Even if it is a normal maintenance fluid, we make our own fluid. And that's why we have to go under laminar flow to avoid any kind of infection to our babies. So we add in dextrose, sodium, potassium, everything is added and we make what we really need for our babies. So it is need-based, not every fluid is prescribed same way. For every baby, it will be a different fluid.
Thank you. Deepika or Jayashree can take up the next question on cardiac. This is about the role of synthetic colloids or colloids by themselves. What is your policy? Do you go, and with respect to the albumin, do you go by any critical level? Will you be alarmed by any critical level of low albumin, or you really don't bother about that? Two questions there. One is about the albumin. The second one is about synthetic colloids. Say, for example, jello fusion.
You
Can
can
I,
take
ma'am?
it. Yeah.
Oh.
Please.
Sure. Just one point I wanted to clarify. Is it for cardiac only you're asking or generally?
In general, But still, its use is much more in cardiac critical care.
And cardiac.
Not restricted to, but much more. Yes.
See, for colloids, like Dr. Jayashree said, that it's never the first fluid of choice. It's only after crystalloids, and if need be, after maybe 40 to 60 ml per kg, if you require fluids and the patient is still, hypotensive, you may use a colloid. Now, in particularly cardiac patients, they are post-surgery, they are more prone to bleeding. If any patient requires colloids more than 30 ml per kg, they are much more higher risk of coagulopathy and bleeding. And colloids per se have been known to cause a lot of renal dysfunction long term. So they can cause acute kidney injury, which happens much later. So colloids is never the first choice of fluid. After using 2 to 3 boluses of fluid, colloids may be used, provided in a 24-hour period, not more than roughly around 30 ml per kg. That is with synthetic colloids, whether it is Hess or Dextran or gelatin, whatever we are using. So small quantity, but knowing very well that there's a risk of acute kidney injury, which can happen to such patients. That's my. For albumin per se, it's not any particular number of albumin which is more important. It is more for the hemodynamic status of the patient. If the patient is hemodynamically unstable, you've already given fluids, then albumin can be used as a safer colloid. And then also we won't be using a hypertonic albumin. We'll be using 5% albumin as the fluid resuscitation fluid. Now, more concentrated albumin can be used in patients like nephrotic syndrome where albumin is very, very low, say like 1.5 or something like that. We may use hypertonic or maybe 20% albumin in those kind of patients. But for volume resuscitation, 5% albumin is most often used because you need albumin to increase the oncotic pressure. Plus, you need the volume also. It can be used as a resuscitation fluid. Anything else, Dr. Jayashree? Yeah.
I think you've covered most of the things, Deepika. My only point is that when we decide to use colloids as resuscitative fluid, then we don't go so much by the cutoff of albumin. The cutoffs we usually go when we are giving albumin to improve the protein content, like maybe in the later part, which is not the resuscitative part. So for resuscitative part, one example is like, let's say a nephrotic syndrome comes with septic shock or a dengue shock, where 5% albumin is something that you would consider. But the same nephrotic, once he stabilizes and goes on to optimization or stabilization phase, and you find that the albumin is now, you can monitor and find it's critically low, then you need to give a higher concentration of albumin. So I think that's what we follow, and that's usually what is.
Thank you.
Right. Since we are on the topic of albumin, maybe we could take input from Dr. Entisar as well. Regarding fluid therapy in nephrotics. It's probably one of the most difficult cases to assess clinically.
So about the fluid and nephrotics, again, it's case by case, because I always get asked about the question, how much fluid should we give? Should we give IV fluid? Should we give oral? Should we just leave the child to drink up to thirst? How much albumin should I give? And when should I give albumin? And diuretics. So then my answer is every child is different. So you need to do an assessment. So those children will, if we're lucky enough to know what was his weight before this relapse or before this presentation, then you will know how much fluid. And we know that the smaller kids, sometimes it's easier to assess if they are fluid overloaded. But then when they come with a bigger size, 40 kg above, then their size and the volume distribution or fluid overload distribution get a bit hidden. And you can't always clinically assess if this child is really over fluid or fluid overloaded. So the concept is that those children, you assume they are fluid overloaded. We know that the fluid is extravascular and it's spacing everywhere, right? Your serum albumin will guide you, because those patients, especially in the first presentation, they come with a bit lower albumin because the case get missed or the presentation get delayed compared to a relapse, which is rarely they would require to be admitted. So those patients in the first presentation, most of those patients would require to be admitted. If not for managing the fluid, will be for the family to get oriented a bit with the disease and the treatment, at least for a couple of days. So the fluid wise, so those patients, the rule is If you know their previous weight, great. If not, then you will have an idea from your history if this child is oliguric in the last couple of days and he's still drinking. None of the parents will come tell you how much intake and output in the last 48 hours, but then you will be getting an estimate by examining the child, where the distribution is, how extensive of the edema, I mean, how extensive it is. That will give you an idea. And if you feel that the child in distress, you'll do an X-ray, look at infusion. Those kids will be most likely having ascites. You don't need much of imaging to know that. Those patients with the fluid, they play it safe to go with the insensible water loss, okay? And for the first 24 hours, you will know the urine output. That's have been said, you have to look at your vitals at admission, because those kids can come with a hypotension, because we know that they are also prone for sepsis. That also might make them hypotensive. So what's their blood pressure? What's their heart rate? What's their respiratory rate? So all their vitals plus their saturation will give you an idea if this child is intravascularly really depleted. If he is hypotensive, if he's tachycardic, then as rightly said, you need to resuscitate them. And the choice here will be albumin. Most or majority of ICUs or emergency will have in hand 5% albumin, which is safe to give it to those patients if you compare to giving them normal saline. So if they are hypotensive, if they are in shock, you treat them like any shock child. But if you have the choice of colloids, then that would be more proper, but that's not available everywhere. So if you don't have, go for saline. Second, those patients, majority of patients won't be really hypotensive, will be either normal blood pressure or high blood pressure, which is mainly related to fluid. Those patients, what you would do, and what we recommend, that you go safely with insensible and do not infuse IV fluids. Go with that number, with the maximum number which you will give them. And in that number, you will include all your medication, including the albumin, because most patients at that point would require to be albumin, especially in the first presentation. There is no magical number. If your albumin below 2.5, more than 2.5 grams, then you are good. If it is below 2, you have to give. No. Some patients are 2 of albumin or even 2.5, but there's so much edematous, you will need to give them albumin and diuretics. It's very important that you remember those patients, if they are hypertensive, it's mainly fluid related. So if you give them albumin and along with diuretics, and usually you go with the loop diuretics, furosemide, those patient blood pressure will come down. Avoid in the acute phase to give them any AC inhibitors or angiotensin receptor blocker, because you will definitely affect the renal perfusion and put them at the risk of AKI, which is very rarely seen in a first presentation nephrotic child. So you have to be careful with dropping that. So to sum up things is fluid, you need to assess your patient, look at their vitals. If they are in sepsis or in shock, you need to resuscitate them, preferably with the colloids. After that, you go safely with insensible loss. And after 24 hours, you'll get more sense of their urine output. You can add that up unless you want really to deficit them and they're so much edematous. Be careful with choosing or jumping on high blood pressure before they're releasing them. And lastly is about the giving only diuretics without giving albumin. That's very, very risky and high risk of thrombosis. Some of us were unlucky, have seen children who died in front of them because of sudden PE or CNS thrombosis, which is very rare. But if you see it once, you know that you should not give diuretics, just send them home.
Yes, the next question is related to that, Dr. Intizar. Maybe you can answer that. For patients on regular diuretics, how often electrolytes have to be measured?
So it depends. This is again a wide question. It depends why diuretics were given, what kind of diuretics, because not all diuretics are so powerful. You need to keep an eye really on electrolytes, because majority of children, when we see them on diuretics, they are either renal patients or cardiac. Majority, right?
Yeah.
Very unlikely to be something else. And again, and some patients, especially the cardiac or even the renal, will be on a combination of different types of diuretics. Those patients, you will need to measure them at the beginning. So usually, let's say a general rule, if they are on chronic diuretics, I'm talking not something for 2-3 days, we give them at least weekly, we'll check their electrolytes. And then when they are on a stable dose, we know those cardiac patients will stay on some diuretics for months till they are big enough to go for surgery, or the surgeon want to take them out of the acute heart failure, phase, and so on, you don't need to follow it every week. If they are on a stable dose, then it's safe to leave them till their next follow-up. Again, there is no one rule applies to all. It depends. The smaller children, I usually get advice the servants more than the older children. So you need to be more careful with that. Again, it depends on your type of diuretics. Are you worried with the hypokalemia risk? Then you switch your diuretics to potassium-sparing diuretics. If the child, if you are changing the dose, increasing it, then you will need to bring the child back within a few days to check their electrolytes and so on.
Thank you.
Most welcome.
Right.
Yeah. Please go ahead.
So we have spoken about the fluids that are required, the monitoring that has to be done. Now, I just would like to ask Dr. Jayashree, when you go for your daily rounds in your ICU and you're looking at the children from volume status point of view, how do you assess? What are the parameters that you look for clinically? And of course, some of the lab parameters.
Okay, thank you for that question, Dr. Kalpana. So basically that will depend again, as I said in my opening few slides, that fluid needs are very dynamic. So our monitoring also will depend on the phase of the illness in which the child is. If the child is in the first phase where we are resuscitating, then obviously we have to look at all the macrocirculatory parameters very closely, the point of care ultrasound to see whether there is fluid responsiveness. So clinical macrocirculatory parameters, the point of care ultrasound to look at the myocardium as well as the IVC, and any other indices for fluid responsiveness if we are using in units like pulse pressure variation or whatever, followed by what is happening to the microcirculation, because we have to correlate our macrocirculation with our microcirculation. So in the microcirculation, we will then look at our SCVO2, that is what is our mixed venous oxygen sats, and of course the lactate and how much the lactate is getting cleared. So clinical point of care ultrasound along with our laboratory indices. This will give us a holistic picture during the resuscitative phase, whether the therapeutic endpoints are being met. Does the child require fluids, more fluids, or does the child require vasoactives, escalation, and what kind of drugs we need to go? If the child is in the optimization phase, that is all this is finished and now the child is just settled and we just have to optimize, then again it will be clinical ultrasound and urine output, electrolytes, and all those monitoring that we will do. And once the patient comes to the maintenance phase, then again we are going mainly by the urine output, how much the child is producing, what kind of volume, and the sodium, of course, is a very important electrolyte to monitor in all critically ill patients. And in the last phase, where we are worried about fluid creep and fluid overload, there we need to keep looking at worsening organ dysfunction, decreasing urine output, further fall in sodium again because of fluid retention. There, then we have to decide whether we need to de-resuscitate or not. So I would say clinical, largely clinical, bedside clinical, some important laboratory parameters. And I think now POCUS has come in a big way. So I think that comes between the clinical POCUS and the laboratory parameters.
So POCUS
We
has
have
become
a daily, it's become just like another clinical variable, I would say. So any chart that we have, so we have a chart where we look at the input, the output, and then we calculate the net balance. And then we look at what is the fluid overload percentage. So our endeavor is to keep the FO percentage less than 5% or between 5 to 10% in children who are on mechanical ventilator. So based on that, we just keep juggling with the fluids.
Right. And since you mentioned fluid creep, I was just curious to know the study that you presented, the Belgian study, how did they actually assess the fluid creep and found it to be more than 30% in that setup? So what was the methodology?
So that was a retrospective study, basically. So they looked at charts that how much fluid was given for resuscitation, how much fluid was given for maintenance, and how much fluid was given for as vehicle. So they calculated and then they arrived at the percentage. So interestingly, they found resuscitation only contributed to less than 10% of the fluid that we give. So I think as Dr. Intezar just said, They don't come with these problems. It's finally we in hospital, by giving fluids, we
Give
create the
them.
problems for them. So this fluid creep is something that we actually end up doing for the kids. So that was like almost 32% in that study, which is a huge volume. And it goes on increasing as the days in ICU keep on increasing. And there was a good question in the chat box, which says that why do we even want to give fluids for 4 days, 5 days after
Yeah.
the child has stabilized? In fact, we should be looking. So I think that is where the fluid stewardship comes. We should be looking for shifting patients to oral or enteral feeds as early as possible, so that all these problems that we talk about, IV fluid creep, will probably be much less in those children who are taking enterally.
Sure. And
Kalpana, can I-
neonatology wise, yeah.
Yeah, because we, what study ma'am had said, we had many these studies which showed that what you had charted and what the baby gets, it's completely different. So in our unit also we say, what did you chart? Just don't look at that when you are charting the next fluid. Calculate the whole thing, what exactly the baby got, really got, and then you can know it, if it is in a positive or a negative fluid balance what you have created. Because sometimes we forget what we are giving extra, so even when you're charting an antibiotic or you are giving a hep saline, so those things are missed. So and sometimes you are actually stopping some fluid for some time. So in the end, actually we always cross check what was charted and what the baby exactly got. And you will be surprised, because very good units, even in them it was not the same. What the was started was not the what baby had received. So that causes the imbalance when we look at the issues.
So you mean the paperwork was different from what the patient actually got?
No, you chart something and then in between you do sometimes subtract, sometimes you have potassium less, sodium less, or something you are adding in between. Then you forget that you had charted something and you have not subtracted from that, or you gave a blood. Maybe it's a dynamic thing which is happening. So that's why we say for a sick baby, please chart every 4 hourly if it is required, so that you don't miss those volumes.
And the choice of fluids, when we were talking about children, crystalloid versus colloids, it was the meta-analysis shown by Dr. Jayashree said colloids are not better. Is it the same for neonates?
We don't give colloids to
At
our neonates. No, we don't give.
Okay.
Dr. Monica, would you like to comment on non-oliguric hyperkalemia in neonates and how do you address it?
Yeah, this is a very, especially in a very preterm babies, this is very commonly seen, because usually you will say that, when you have a renal failure and the baby is not passing urine, that is the time when you will have hyperkalemia. Now, in this premature babies, what's happening is that because of the sodium potassium ATPase gymnasium, which happens in first 24 to 36 hours, the babies continue to pass urine, but from the intracellular, the potassium is coming to the extracellular fluid, and hence the potassium levels goes high. So potassium usually you will see 6.7 or something like that potassium with a normal urine. This is physiologically happening, where you will not be really doing much. The problem happens when this same physiology goes overboard and your potassium reaches 8, 9, where you will have arrhythmias issues and all those issues. Earlier, if you look at the history, 60% of our premature babies used to be having this non-oliguric hyperkalemia, and they were requiring treatment. Now, fortunately, because of the antenatal steroids which we have started giving to our mothers who are going to deliver premature babies, it stabilizes this sodium potassium ATPase and has reduced our non-oliguric hyperkalemia, but it is not fully vanished. And also we are looking more strictly into the in the fluid balance, so it is less. So treatment would be same, like if you see a 6.7 of potassium, baby is fine, please don't go ahead and treat, because it is going to get okay by itself after 36 to like 48 to 72 hours, it's going to get okay by itself. So you really don't need to treat it. However, if you have a potassium which is going beyond 8, you will have to, and it is causing some arrhythmia, you will have to give agents like calcium to, how you treat hyperkalemia, or you may have to give bicarb, or you may have to give, sometimes if it is too much, then also we may use sometimes salbutamol nebulization to treat this potassium. We should always do an ECG to see what's happening to the really, if it is really causing a problem, then only we need to treat it. And sometimes, very rarely, you may need diuretics to get rid of it, and very rarely we may need MAM and TSR to come and do the dialysis.
Thank you.
Yeah.
Dr. Intisar, do you want to comment on the role of peritoneal dialysis versus CRRT in resource-limited pediatric intensive care units?
So as you correctly said, resource limited. So it depends on what you have, because I can come and tell you in cases with the metabolic kids with the ammonia 1000, better you do CRRT, but then, or hemodialysis, but they don't have it, or you can't do it for whatever reason, access, whatever, name it. So patient with, again, it depends on the setup. It depends on the expertise. Whom do you have? There is no one fits all. So BD usually the safer in those patients who are very sick, having DIC or really hypotensive and very high dose of ionotropes. BD might be your solution to do it. Giving a high risk consent, taking them to the OT, or putting it as a bedside as a BD catheter. So BD is always safer. Hemodialysis is the ideal solution, and many intensivists do start and run the CRRT by themselves without even consulting nephrology in some units. CRRT had been big modality and been widely spread now with different companies offering different size of dialyzers or filters and the bloodlines compared to 10-15 years ago. So again, here, there is a lot of factors. The size of the child. Are you able to put BD catheter versus hemodialysis? How stable is the child? What's your aim of doing the dialysis and how long it's going to be? Does this child has a pre-existing renal problem and then just came with acute on top of chronic, or has a normal or expected to be recovering, let's say, from this renal impairment? That's again another factor, because if you put a CRRT and you know that this child ultimately will be losing their kidney forever, then maybe a BD a better option, because that will easier convert them to home dialysis. Again, there is many factors, patient-related, center-related, physician-related, saying which one to go with, BD versus hemo. So in the ideal world, CRRT in ICU patients. In not so ideal world, which is majority of the centers, you have many factors to tell you which one to do.
Sorry, I'm interrupting. Dr. Intisar has to leave. And I would like to request the moderator not to direct question to Dr. Intisar. Thank you very much, Dr.
That's okay,
Intisar,
no
for
worries.
being with us.
Sure.
Thank you. Thank you very much.
Thank you very
Thank
much.
you,
Thank you
doctor.
very much.
Thank you.
Thank you. I enjoyed it.
Thank
Thank
you.
you. Have a good night.
Thank
Take
you.
care.
Right.
Thank you. I would like to ask my PICU colleagues and to take up the next question. It is about in diabetic ketoacidosis. Do you try that for fluid correction in a DKA? This is mainly because whenever we prescribe fluids in the classical pathway of 10% dextrose with saline and potassium chloride, and again changing it 5% dextrose, etc., either if it has to come from the pharmacy or locally made by the nursing staff, it takes time. There is a reasonable period of time when patients end up not being on the fluid or same type of fluid being continued despite changes in the in the blood glucose. So do you try this 2-bag method? It's mostly tried in the US. One of my Canadian colleagues, while I was at Mafraq Hospital, she is also a great favorite of that. It is practically 1 bag will be containing normal saline with the KCl and the other one containing 10% dextrose with normal saline and KCl. So by changing the proportion of fluid, by mixing the proportion of fluid from one bag to the other, you can achieve the same result depending on the blood glucose level. Have you tried it?
Practically speaking, I personally haven't tried running both the bags together. Initially, we start without dextrose. Once the sugar is coming down, obviously, once it's nearing 200-ish, 250, we start with the dextrose fluid. But for running both the fluids simultaneously, I haven't tried. I keep both the bags depending on the sugar. We just switch this on or switch that off. But running both together, like you're saying, the ratio 25-75 or 50-50, that way I haven't tried personally.
Okay.
Sorry, please continue.
Sorry, yeah. So, Sunil, you're very right that this is followed in most units in UK, this 2-bag system. And as he said in his opening remark that the time to switching the different concentrations of glucose or electrolytes is less. So the blood glucose variability, which was seen in certain studies, was much less with a 2-bag system as compared to a 1-bag system. We did it as a part of a randomized control trial, which we published, where we tried using a 2-bag system to see for a primary outcome, which was glucose variability. However, as a routine method, I think the nurses need quite a bit of training for this, to use this. As a part of a trial, we were able to do, but subsequently, it has not become a routine in the unit. So the nurses are comfortable with whatever is going on. With that, the DK treatment goes on quite fine. But in many units, this is practiced. I think it reduces the wastage. I think that's a very important thing because you have to keep changing bags otherwise. By altering the concentration of glucose and the electrolytes, the wastages and the glucose variability can definitely be controlled here.
Thank you.
Another scenario that there is a question about is burns. And I think Dr. Diari also had sent us a question regarding fluid management in the first 24 hours in burns cases to ICU. So Dr. Deepika.
Okay.
Dr. Diari is not joining us.
He was here.
Yes, please.
So for burns, like everybody knows, the total amount of fluid that is required is based on the Parkland formula. That is like 4 ml per kg of the total burn surface area. Plus we add that, to that we add the maintenance. Now, half of it is given initially in the first 8 hours, and then subsequently the remaining half is given over the 16 hours. When we are doing the initial resuscitation, what we need to take into account is that suppose a patient is hemodynamically unstable and we give a fluid bolus to that patient, that fluid bolus also needs to be included in that first hour fluid. And then though we calculate like this for 24 hours, but we still need to monitor intake output and urine output, because sometimes we find that by calculating based on the Parkland formula, they're actually passing a lot of urine. We have to aim for something like 1 ml per kg per hour. Anything more than that, anything if they are like 2 ml per kg per hour or more urine they're passing, probably they do not need that much fluid. Because if you give extra fluid, it will cause tissue edema. That will again impair the healing. So strict input-output maintenance and starting with the crystalloids only and doing the resuscitation. First 50% the fluid in the 8 hours, remaining 50 over 16 hours. Usually colloids are not used as the initial resuscitation fluid in burns. Maybe they may be needed after 24 hours, but this is how we strict input-output targeted to the urine output. Aim for only 1 ml per kg per hour, that is enough. If you're passing over, you have to dial down on the fluids, isotonic fluids.
So another question was regarding omphalocele or gastritis. I think that's what he wanted to know. How do you deal with those cases?
This is for me. I got surgical actually.
Yeah, surgical.
See, patients who have any abdominal pathology, particularly if there's an open abdomen, they tend to lose lots of fluids. So they may again need more than the maintenance. So here again, based on the patient's, each case is different. So based on the intake output chart, urine output, perfusion indices, they may need more fluid. So any abdominal surgery or any of the congenital anomalies, gastritis and all, usually they lose a lot of fluid from the intestinal mucosa. So we need to monitor the clinical parameters, the sodium, urine output, and perfusion also. So they may need extra
probably they
fluid.
require more intensive monitoring.
Yes,
in
yes,
order
definitely,
to get around the
definitely,
problem.
definitely.
We have
Electrolytes
to
and
also
sodium.
cover it, Dr. Kalpana. We
Avoid
need
the
to cover
loss.
it. We need to actually make it hydrated,
Yes.
and so that there is the
Losses are
losses
less.
are reduced. So that is very, very important when we manage this omphalocele.
Mhm.
And recently we had one case from India. It was a huge omphalocele which was surgically corrected, but before that, how to cover it, how to keep it hydrated and keep it out of infection, that bag which we have to create, that is very important to reduce this fluctuation of the fluid imbalance.
Yeah. I think his next question is to Dr. Jayashree about fluid management in patients with localized and generalized peritonitis.
So what exactly, I mean, I don't
Is there
understand
anything
keywords.
specific from fluid management point of
No.
view? Is what?
So basically what they say is that wherever there are spacing or losses, third space losses, like what would happen if you have a peritonitis, then depends on how hemodynamically stable or unstable the child is, or whether there is an associated septic shock or it's just an enclosed space infection. So the principles of fluid would be something very similar to what we would do in any other sepsis or septic shock and third spacing which occurs. What kind of hemodynamic parameters and how we need to resuscitate.
So it will be similar.
I'm not understanding the question completely. I'm not aware of anything which is very specific for this kind of situation. Maybe the other panelists would be able to chip in.
Yeah, maybe Dr. Sunil, any ideas on this?
If the child has a drain for the peritonitis, if there is a drain for the peritonitis and there are losses which are occurring through the drain, then generally it's said that losses through the drain need to be replaced with isotonic fluids. So I think the replacement would be isotonic.
Yeah.
If there is a drain for the peritonitis.
Yeah, I agree with that, Jayashree, but one of the conditions to be kept in mind is about SIADH when the child is so sick. In those conditions as well, that can add up in management of fluid balance in children with generalized peritonitis, as they tend to have some blown up picture with capillary leak also. That has to be considered as well.
So then I think isotonic fluid would be, that's why would be a better option so that it can take care of the hyponatremia, SIADH induced hyponatremia and other complications.
Yeah.
I would like to interrupt and ask one question. Can I?
Yeah, sure, doctor.
Yeah, one is actually in diabetic ketoacidosis, it was a trend to start to give as other dehydration 20 ml per kilo. Recently, they changed it to 10 ml. I would like to request panelists to give their opinion regarding this. And of course, there is another question I'll ask. It is diabetic ketoacidosis initial fluid management. Dr. Jayashree?
So you're right, Dr. Saurabh. So in diabetic ketoacidosis, if the patient is not in shock, so presence of shock. So after having said that, presence of shock or hypotension in diabetic ketoacidosis is not a very common occurrence. If somebody has come with hypotension and is in decay, then it's more likely to be that the child has presented very late to us. So that's very uncorrected hypovolemia for quite some time, or there may be an associated septic shock. The infection which has triggered decay must also be leading to septic shock. So these are the two usual conditions where a child with decay tends to present with shock. Otherwise, for the garden variety diabetic ketoacidosis, usually we don't see shock. Their intravascular volume status is relatively well preserved. They have dehydration, but they don't go into shock. So if the child is not in shock, then the first hour fluid, there is no hurry to give it in 5 minutes, 10 minutes, 15 minutes. So it can be given over an hour. So the rate of the first hour fluid, you can take about an hour to give. And the bolus requirement is only there if the patient comes to you hypotensive or comes to you in shock. So this is one
What I meant to
important.
say that before they used to give 20, now they are recommending 10 is enough.
It's less, 10
Don't
10
go.
ml. Yeah, yeah. So now again in DK, just like we saw for the septic shock, I think pretty much, I think it's same for most things in critical care, whether it's ventilation, antibiotics, fluids, or DK management. One has moved from liberal to more of a restrictive strategy, because more the fluids again is going to cause more problems in DK in the form of therapy related cerebral edema. So if you see the recent DK protocols, even again the same problem there, the assessment of dehydration, we tend to overestimate the dehydration. So that again will cause more problems of cerebral edema, fluid overload. So therefore the dehydration correction is also less. The insulin also from 0.1 you can use a smaller dose like 0.05. The fluid bolus also from 20 it is come to 10. And the rapidity with which you give the first hour is also, you can give it over 1 hour. So again, most things gearing up towards a restrictive strategy.
With permission of moderators, if a child is very obese, as we know, in obesity, the calculation is also on the ideal weight of the child. If a child is very obese and come, how you calculate fluid on, weight basis? How you calculate fluid for those children, very obese?
We tend to go by calculation of the lean body mass. It can be calculated from the formulas or from the internet. It is available. So we have to take the weight of the patient, as you're saying, obese, and the height of the patient. By putting those two criteria, you can get the lean body weight, which is an ideal weight for that patient to take the calculations, and we go by that. That is our practice. What are the practices from different departments? Ideal body weight for an obese patient. Obese patient. We go by lean body weight.
I wouldn't be able to throw much. We see the other end of malnutrition more than the obese patient. So no, offhand I wouldn't be able to give you an answer to this. I'm not
Yeah. The formulas are easily available, Dr. Saurabh, over the internet for calculating lean body weight, and we can go by that by calculation.
Thank you.
We also use the ideal. Yeah, we also use the ideal body weight based on the age of the child, because generally speaking, obese patients have more adipose tissue. Their total body water is much less. So first thing, their requirements are much less. And then if we give more, they tend to get more edematous, more hyponatremic. So ideal body weight based on that, whether it is fluids, whether it is drugs, antibiotics, everything based on that we calculate.
What I remember when we were doing our MD post-graduation, we were taking 40 kg as the cutoff to calculate everything. Even if the baby is 50, the child is 50, 40 was the one which we were doing at that time. I mean, it's long time back. That's what we were doing. We were not giving like, if the child is coming 50 kg, so we were not calculating 50 kg, then we will calculate as an adult, you know. So it will be the 40 would be the maximum cutoff. That's what we were doing earlier. I don't know.
I think it's time to close the session now, Dr. Saurabh.
Can I one point? Can I ask? Can I just say, not point, one of the questions I had seen in the questions that were answered when Dr. Khalid had asked about if a child has some meningitis, some ICP and hypotension or a volume
raised
depletion.
ICP and hypovolemic shock, what will you give preference to?
Absolutely. I mean, this is a very, very valid concern if somebody has, they are worried about cerebral edema. But here I'd like to say that volume resuscitation is more important, because if you optimize the map, your cerebral perfusion pressure will improve. ICP would sort of come down. So obviously in this situation, hemodynamics takes first perfusion, first preference, and isotonic fluid. Okay, that was my.
You
Thank
can
you
use
very much.
3% saline also. This is one
Yes.
situation where you can, if you know there's cerebral edema and patient also has hypotension. So as Dr. Deepika said, systemic perfusion optimization is primary. You can use 3% saline in these patients, which will act as a volume expander as well as also help in your cerebral edema.
Regarding this 3% saline, I was reviewing some of the studies. Although 3 to 5 ml per kilo, it has been mentioned, but in one said you give 150 ml over 20 minutes, and in the same time you go on analyzing the patient and see the level. If it is less in next 20, again 120 you can go. I mean, up to that level they were going. I think now it is in India. It's going to be 2 o'clock. I would like to thank Professor Jayashree for excellent presentation, discussion. Dr. Indesar, Dr. Deepika, Dr. Sunil, Dr. Monica, Dr. Kalpana, Dr. Diari, all viewers. Still we are having around 500 following us. Thank you very much. Dr. Indesar asked me how long it will go. I said it may go to 12 o'clock because people are asking questions, discussion. I myself, I have 100 questions. In fact, I did my thesis in 80s under Dr. Singhi. That time, fluid and body water changes in severe asphyxia was there. In fact, I presented this in front of Professor Victor Yu from Monash University, Australia, who has done a lot of, he invited me to Australia. That time, it was very difficult. As Dr. Monica said, fluid restriction is the main. So I would like to thank all of you. I'd like to thank viewers. I think we will have another session of, because this PICU, we have to go different condition in PICU because usually webinars are not conducted in this. Thank you very much. I would like to request Dr. Kalpana concluding. Well, we would like to thank Tawfiq for sponsoring, Tawfiq, Fadi, and all viewers. Dr. Kalpana, please.
Yes, thanks to all of you. Now, as I already intimated that, this is a very vast topic and we need a lot of revision. We need a lot of, reading. So what has helped you? If you can give us 1 or 2 references, if anybody wants to say that, I would appreciate that from the panelists. Simple references, which, practical, which pediatricians can go to. If you have ready references, well and good. Otherwise, you can send it to us and we will post it.
Is it okay if we...
Yes. We can post it in our
review articles.
group.
There are good review articles and papers. I think what I'll do is I'll give the list to you.
Yes.
So then you can give it to
so that would be nice, doctor. Then we will circulate it. So thanks a lot.
Thank you.
Yeah. We learned a lot. Thank you.
Yeah. Thank you, everyone.
Thank you so much.
Everyone.
Thanks a lot.
Thank
It was
you.
a pleasure
Good night,
interacting with all.
Good night,
Thanks a
everybody.
lot.
Good night.
Good night.
Bye. Good night.
Thank you very much. Good night. Thank you. Thank you.